All right, the recording should be started. So hello to everyone who will be watching this later. So thank you again all for understanding about the shift in overall format. Hopefully everything will run smoothly and it will be more functional than an actual lecture, and we'll be able to kind of get everything that we need to done before the midterm. So you are also, for those of you who haven't used Zoom before, you're also welcome to chat any questions. The chat should be kind of on the side panel. I will see questions as they come up. If you don't really feel like speaking up, totally fine. We can do that instead. So just let me know if you have any questions throughout. Stop me at any time. We'll kind of be going in and out of different things. Want to finish off the lecture from Thursday of last week, start the lecture and finish it today, and then go over any questions that anyone has on the study guide at all. That's kind of the plan of attack today. Any questions about anything, just starting off? How's everyone doing? I know it's hard because I can't see all your faces, but everyone have a good weekend. Anyone have any questions that came up during the weekend that they wanted to talk about now?
I have a question. At the end of this lecture, are we going to be able to ask you questions on the study guide?
Yes, so we're going to save enough time to do that. The experimental studies lecture, we're going to go through some of the parts. I don't want to say quickly, but I'm going to highlight, I would say, the more relevant parts for the exam that I want you to focus on. So even though it feels like a full lecture, we won't actually be spending too much time going over kind of all the components. So we'll try to save at least maybe 10 to 15 minutes at the end for any questions that you have on the study guide. And that will be recorded as well. So anyone who wants to ask questions and hear the answers again later, will have that same access on the YouTube link. So any other questions about anything at all for now? Anything at all? Okay. Again, if you have them, feel free to unmute your mic or chat in the chat box. Happy to answer as we're going along with things. And I'll kind of read off the questions as they come up in the chat, so anyone who's listening to this afterwards can actually hear the question as well. All right, so let's follow up, finishing off our case control lecture that we had talked about on Thursday of last week. So we had just finished our discussion of calculating an odds ratio. So we're going to kind of pick back up there and talk just once again about the interpretation. So the key thing with odds ratio to remember is, same thing with prevalence ratio, same thing with any ratio that really isn't in a cohort study that we're doing. The big key words to avoid are risk, right? And so if we're looking at the interpretation, we're really comparing the odds that cases were exposed compared to the odds that controls were exposed. So our interpretation should all focus around that. So, for our example here, we had the odds of exposure in cases, and just to remind you of the actual calculation that we did last time, let me see if I can do this well. And let me know if for any reason you can't see my screen. So the odds of exposure in the cases was 130 over 70. The odds of exposure in controls was 80 over 120. I don't know why I keep typing 120. Right, and then we talked about two different ways to get to the odds ratio. You can use absolutely either one, totally up to you. So 130 divided by 70 divided by 80 divided by 120. I know we had done this calculation in class, but just as a review, that got us approximately 2.79, 2.78. So we could also have done 130, same thing we would have gotten, 130 times 120 over 80 times 70 would have gotten us the exact same answer. So with the odds ratio, you can do either format, either one would work. And so just going over the interpretation in that context, you have people who have coronary heart disease have 2.79 times the odds of being obese than people who do not have coronary heart disease. Another way of saying it, the odds of being obese in people with coronary heart disease is 2.79 times the odds of being obese in people without coronary heart disease. We can absolutely say it out of context as well. We can say the odds of being exposed in people with coronary heart disease is 2.79 times the odds of being exposed in people without coronary heart disease or just disease. Either would be totally fine interpretation-wise. So last thing I want to mention, any questions on overall odds ratio interpretation? Yes, I can see the screen, but I can't hear anything. So someone asked, for anyone who can see what I'm doing but can't hear anything, it might be an issue with the audio on Zoom. And again, this is relevant for anyone who walks into the room or comes into the room. If you join audio via computer, that might help as you're going through things. If, it could be a volume issue depending on where it is. Also, know that everything will be recorded though. So if for some reason you can't get the audio to work on this, we will absolutely be able to, you will be able to hear it on the recording. So give me 1 second to just respond to this. Okay. So just responding to, again, someone having a little bit of technical issues. All right. So let's keep going. Clear this and go over one more thing regarding interpretation. So with the interpretation of the odds ratio, when I ask you for the interpretation, what I'm interested in is, what we just talked about, the people who have coronary heart disease have blank times the odds, and so on. I might also ask you what that means. So again, the nice thing with ratios is all of the ratios that we've talked about, prevalence ratio, risk ratio, odds ratio, all really have that same, for the attack rate ratio, all really have that same format of, if it's 1, it really means it looks like there doesn't appear to be an association. If it's greater than 1, in this case, the odds ratio is greater than 1, it looks like the odds of exposure in cases is greater than the odds of exposure in controls, meaning it looks like there's an association between exposure and disease. Specifically, it looks like there's a positive association, right? In this case, exposure might be a risk factor for developing disease. If the odds ratio is less than 1, it's the opposite. It looks like there is an association, right? The only no association one here would be 1. But if the odds ratio is less than 1, it looks like the odds of exposure in cases is less than the odds of exposure in controls. So it looks like a negative association exists. It looks like exposure may be a preventive factor for disease. So if we were talking about something like, going back to our context, we said obesity and being obese might be a risk factor. Obviously, we had an odds ratio we went over of 2.78, that is above 1. So in that context, it looks like obesity is positively associated. It looks like obesity may be a risk factor for disease. If we had a risk factor like, we'd had a factor like physical activity, engaging in physical activity might and likely would show an odds ratio of less than 1 for heart disease, meaning people who engage in physical activity appear to have a lower odds of disease. So it looks like physical activity is preventive for disease. So again, similar to the attack rate ratio, similar to the risk ratio, similar to the prevalence ratio, really look at whether or not that odds ratio is above 1, below 1, or at 1 to kind of say what that means. Interpret what that kind of means outside of the context of just that sentence. So any follow-up questions on odds ratio? I know we had kind of talked about, finished off our discussion of this last time, but I just wanted to revisit this. Any questions at all? And remember, know that you do have the odds ratio, you do have the practice problems. You will have your homework, which is due today. Again, remember your fourth homework is due today. You will have odds ratio practice problems on your homework as well as on that, and I'll pull it up at the very end of class today on that, what did I call it? Practice problem, study design practice problems. So you have the practice problems and answers there as well. All right. So let's talk about, just like we've done with all the study designs, one of the things I want you to focus on is going to be the advantages and disadvantages of a case control study, in addition to the processes of a case control study and that calculation. So some of the best advantages of a case control study, they're useful as a first step. We talked about some of our remember, case control kind of falls in the middle. We said ecologic studies are our weakest design, cross-sectional are next, followed by case control, followed by cohort studies, which are our strongest observational design. Case control can be a better choice if you're not exactly sure if there's going to be funding, there's going to be resources to conduct a full cohort study, but you still want to do a relatively strong study design. Case control could be a good way to go before a cohort. I would say probably the single, not best advantage, but one of the reasons why a case control might be used even on top of a cohort study, even if the resources are available for a cohort study, is if you're working with a rare disease. We talked about cohort studies are not good for rare diseases, right? Because with a cohort study, you're following people over time. There's that period of follow-up that you have to follow people for years and years and years to, often. So you're essentially waiting for disease to develop. Well, if you have a rare disease, it's probably not going to develop in a lot of people because it's rare. And so what you can do in a case control, the advantage there is, remember, case control, you're choosing based off disease status. So you can choose all the people who have disease, and that can be the start of your study. You're going to compare them to people without disease, right? But you can study rare diseases in a case control, which is great. They tend to be quicker than cohort designs. Again, remember, cohort study have that follow-up, case control do not. So they tend to be quicker, relatively inexpensive comparatively. And the nice thing is, unlike with cohort studies where we're really looking at one exposure, and then we can look at multiple diseases, in a case control, you can examine multiple exposures, but generally you're looking at one disease. So it's kind of the opposite of what you're doing in a cohort. So a case control, you can examine multiple exposures. In a cohort study, you can examine multiple diseases. Depends on what you're looking for. And then in terms of disadvantages, we've already went over kind of a lot of these just inherently as we were discussing case control studies. One of the biggest disadvantages is we can't calculate risk directly. We said the big, important, great thing about a cohort study is we can calculate risk, which we love, which we want to do. We cannot calculate risk directly in a case control study. We can only calculate that odds ratio, and we can estimate risk in certain situations that we haven't really talked about, but that we're not going to worry about too much. But generally, we're calculating that odds ratio. Just as in other studies, it can be hard to verify that case diagnosis. Again, that's really true of any study that we're doing, but because a case control is relying on correctly identifying people with disease as kind of your starting off point, right? That's what we're grouping people based on, people who have disease, people who don't have disease. So it can be hard to verify that case diagnosis. Exposure ascertainment can be difficult as well. Again, that's true in a lot of studies. It can be hard to verify whether or not someone's exposed. So I would say those aren't necessarily unique to case control, but are definitely present in case control. And then one thing that was an issue in our other study designs that is an issue with a case control as well is that issue of temporal ambiguity. Remember, temporal ambiguity, temporal refers to time, Ambiguity is that uncertainty. So temporal ambiguity is that uncertainty with that time relationship, right? We don't know which came first, exposure or disease. Cohort studies, we didn't have to worry about that as much because we were identifying people who had exposed and unexposed and then following them to see if disease developed, right? We were kicking out anyone who did have disease at the beginning of the study. But with case control, again, it's an issue just as it was in a cross-sectional, just as it was in an ecologic study, because we don't have that clear time relationship. It's also, we talked about the difficulties in finding controls. There's a lot of different places to select controls from. I'm not going to ask you about all the different places there are, but I kind of want you to have that idea of, you can choose those best friend controls, neighborhood controls, hospital controls, but it comes up, well, which do you choose? There's so many different choices. That'll depend on the study. Case controls, just like all of our other studies, are subject to several different biases. Biases we'll talk about in the next kind of segment after the second midterm. But biases are essentially things that can mess with your data, things that can cause distortions in your data. And lastly, for disadvantages, we talked about on the last slide, the good thing about case control is they can study multiple exposures. The bad thing is we can usually study only one outcome, one disease, because remember, we're grouping people based off disease, right? So that's, where I'm going to leave off on case control studies. Any questions, though, in general? Because I know we've talked about a lot of study designs. We're going to talk about one last one today. But any questions on case control studies at all? I do think case control versus cohort, it can be a little confusing because a lot of, again, advantages of one or disadvantages of the other. And so any questions in general about how a case control works? I'm going to just, again, pause just in case anyone's typing a question. All right. Again, you can type your question. You're welcome to grab the mic. You can just unmute yourself if you want. Absolutely fine to do either, just whichever you prefer. All right, so I'm going to stop sharing my case control slides. I'm going to pull up these slides from today on experimental studies. All right. Can everyone see the slides okay? Or can anyone see the slides okay? Let me know, just chat yes or say yes, just so I know. Yes, okay, perfect. Excellent. Just wanted to make sure before I keep going and then realize no one's there. All right, so the very last lecture that we're going to talk about before the midterm on Thursday is going to be randomized trials. So as I mentioned at the very beginning of today, and kind of mentioned last week, we're going to, I would say, we've already touched on a lot of concepts in general with randomized trials in that broad context of the difference between experimental studies and observational studies. So this is the only lecture that we're going to talk about experimental studies. There are some places where to allow enough time for questions at the end, I might skip over or move fairly quickly over some points intentionally if it's not going to be a huge focus for the exam. And I'll let you know where those are. So, but just know, I want to spend as much time as possible going over kind of the important relevant points with randomized trials. So let's go ahead and get started on that. The key features of randomized trials or experimental studies, and we'll talk about kind of what a randomized trial is compared to an experimental study in just a couple slides. The key features are actually ones we've really already discussed when we were talking about the difference between experimental versus observational. We said observational studies, and we talked about 4 of them, right? Ecologic, cross-sectional, case control, and cohort. All 4 of those were observational study designs. Experimental studies differ, and all of you did really well on, I think I asked this question on the midterm, we've kind of talked about it several times. The big key feature of an experimental study is the researcher determines or controls the exposure for study participants, right? In an observational study, we're just asking, are you exposed? We're not telling people, oh, you have to smoke for the next 20 years. We're asking if they do smoke, right? So the researcher determines or controls the exposure for study participants in an experimental study. This is a study where I tell one group, take this drug. I tell another group, don't take this drug, and let's see if a headache improves in both groups. So it's that level of control of the researcher over the exposure. And again, it's not forcing, it's just control of designating who is exposed and who is not. That's what makes it an experimental study. That's, I would say, the number one key feature is that control over exposure of the researcher. Now, the next two are kind of similar to a cohort study in some ways, especially number two. One group is exposed to a factor and the other group is not. This is really true of a lot of our study designs, right? We have an exposed group, we have an unexposed group that we're comparing it to. That's true in an experimental study as well. One group is exposed, the other group is not exposed. What an experimental study is trying to do, and we'll talk about how randomization comes into play. What an experimental study is trying to do is it's attempting to obtain an unbiased estimate of the effect of treatment by comparing the incidence of outcome in both groups. Essentially, we're trying to get at, does exposure affect disease? And there are reasons why that we're going to talk about why an experimental study is really our best study design in terms of most powerful. We said our cohort was our most powerful observational design. Our experimental study is just our most powerful design in general because of the ways that we're going to talk about, because of the added level of control that we have. Doesn't mean all experimental studies are good. Doesn't mean we can always do an experimental study. But in general, if done correctly, they tend to provide the strongest evidence that an exposure is related to a disease. Doesn't prove anything at all, but definitely provides stronger evidence than some of the other study designs. That's why we kind of consider it the gold standard. If we can do an experimental study, if we have the resources, if there's other factors that are allowing us to, it can be a really good choice. All right, so let's kind of break down what an experimental study looks like. This will depend on what you're actually looking at. So we have our study population. We group them into a treatment group or an exposed group, and we compare that with a control group or an unexposed group. Confusing because control is used in a slightly different way than it was in case control studies. In an experimental study, your control group is essentially your group that doesn't have the treatment. It's essentially your group that is unexposed. So we have an exposed group, we have an unexposed group. We could absolutely have more than two groups, but in general, let's say just for our purposes, we just have two groups, treatment and control. And then we follow them to see what happens. Just like we did in a cohort study, design-wise, a cohort study and an experimental study are very similar. The difference is that level of control. We are assigning people to treatment and control groups in an experimental study, whereas in a cohort study, people are telling us whether or not they're exposed or unexposed. But we're following people over time to see what happens. Did they improve? Did they not improve? Did they get worse? Did they not get worse? So it totally depends on what we're looking at. So we have two different types of experimental studies that are relevant that I just kind of wanted to mention. We have the classic clinical trial. Clinical trial really, is what I would say most people think of with an experimental study. A clinical trial is really where we have people as individuals who are the subject of the study. So we're still grouping them into people who are our treatment group and our control group. But essentially we have people that we're assigning individually to each group. So kind of a classic example, there was a clinical study done in hand washing. So looking at hand washing and hospital practices to see if people who wash their hands in a certain way had a certain amount of bacteria still on their hands compared to people who did not wash their hands in that way. So we're essentially assigning people, you wash your hands this way with this, it was looking at soap versus alcohol-based hand sanitizer. So you wash your hands with soap, this group washes their hands with hand sanitizer. Let's compare the two groups to see any differences that we see in bacterial load on hands. And we'll focus mainly on clinical trials, but I do want to mention community trials because I think they are an interesting subset of experimental studies that often get overlooked. So community trials essentially are studies where the subject of the study is a community. Essentially, we are in a community trial. We might be looking at entire populations that we're comparing to another entire population. So let's say we would do, and I'll give you a famous example, back in decades and decades ago, they wanted to test water fluoridation and to see if fluoride in water could have an impact on whether or not someone develops cavities. So what they did, because they didn't really want to do that on an individual level, because essentially that's providing people with water on an individual level for quite some time, what they did was they introduced water fluoridation into communities. So they kind of chose different communities to introduce water fluoridation into, and they compared those to communities where there was no such introduction of water fluoridation. And they looked at what happened to those two comparison communities. And actually, in that study, it was found to be so beneficial. The number of cavities went down in the communities with fluoridated water substantially. And so they actually wound up cutting that community trial a little bit short because they found that that was actually, a very beneficial practice in a lot of ways. So most places in the U.S., there are some places that don't, but most places in the U.S. do have fluoridation added to water because of the benefits that it's been seen. But that would be something done on a community level. So we're looking at, anything that can't really be done as well on an individual level. So let's say, a new law that's being enacted or a new billboard that's being put up, a new air pollution system that's being introduced. We can't really do those things on individual levels, right? We could only really do those things on a larger scale community. And so in that case, we would compare different communities. We can, for both of the studies, we can do kind of one of two things. We can either compare, same with community, same with clinical. We can compare different groups. So with clinical trials, we can compare different people. With community trials, we can compare different communities. So there was one question, can you mix the type of group? For example, individual comparing to group or group comparing to individual. Great question. I would say generally no. Not that you can't, but you would probably not want to do that. You would generally just say, and again, individual can be your group, you can be grouping individuals. So generally, if you can do something on the individual level, you would probably want to stick with the individual level. So, distributing a drug, you would want to distribute it to, a group of individuals, obviously, but you would distribute to an entire group versus necessarily mixing it with a community and comparing it that way. So you would usually stick with comparing communities to communities or individuals to individuals. But again, individuals could be groups. It's really when you're choosing a community trial, it's because you can't do something on an individual level. You can't really, again, like the fluoridation example, or let's say you were looking at whether a new seatbelt law had any impact on motor vehicle fatalities. Well, you couldn't really do that on an individual level, right? Because you couldn't necessarily assign some people to wear seatbelts all the time, some people not, but you could look at communities where this law was enacted and say, okay, are there less fatalities in this community versus another one? So that would be more of a community trial. So, you know, as I mentioned, you can do them just as we said, kind of comparing differences between different groups or different individuals. You can also compare a before and after in an experimental study. So you can look at, you know, an individual, kind of a group of individuals, people in your treatment group, and you can say, all right, how long does a headache last in people without this drug? And then let me give them this drug and see how long a headache lasts in people when they're on this new drug. So that would be kind of a before and after in the same individual. So you're comparing people kind of to themselves. So you can do the same thing in a community. You know, what were the traffic fatalities like before that law, you know, the seatbelt law was enacted? What were they after? So either way, you can compare different groups to different groups, or you can compare the same people before and after. So any additional questions about the differences between the kind of two, I would say, broad categories of experimental studies? We're going to focus on clinical trials because I would say that's the more common one. But in essence, they work very similarly in what we're doing. But any questions? Again, I want to give it, you know, plenty of time to ask questions on the more, I don't want to say relevant, but the more relevant slides. And then there are a couple slides in there that we will skip over quickly just because they're going to not, I want to mention them, but they're not going to be as relevant for the exam. All right. So let's talk about steps in conducting an experimental study. Really the first step, and the first step in most of our studies, was to specify our hypothesis, right? So we want to specify our hypothesis. Then we want to specify a target population of interest. So essentially what a target population is who you want to make claims about in your study. So let's say my target population is all US university students. I want to make claims about how something works in all university students in the US. From that, I might choose a smaller population, what's called the source population. So our outside one is, let me do text. Our outside one is the target. Our inner one here is the source. Our source population. So maybe this is all CSUN students. Should have done it again, text again. All CSUN students, right? So I want to make claims about all US university students. I'm going to choose from people who go to CSUN though, just for convenience, and oftentimes it's done because of convenience. And then likely you will have a smaller subset. This is what's called your actual study population or your sample. Those are the actual people that you have in your study. So maybe I choose from all of CSUN students, but maybe I don't choose them all. Maybe I just choose a subset of 100 CSUN students. So your target population from your study population of my 100 CSUN students and the relationship that I see there, I want to try to make claims about all US university students. US university students would be my target population in that case. So you want to specify who you want to make claims about. Your next step is you're going to want to define all the things of interest that you want to look for in your study. You want to define major and minor endpoints and any possible side effects of treatment in your study. So what are you looking for? What are you attempting to measure? Your next step is recruiting a study population. So I'm sure many of you have seen these kind of flyers. Do you have high blood pressure? Do you know someone with diabetes? Do you know someone with X disease? Be in our study, right? So that's one way of recruiting people. You can get people into your study, and we'll talk about incentives in the ethics lecture after the midterm. But essentially, you're really trying to do whatever you can to recruit people in. And there are limits on what you can do incentive-wise to try to help with that. You're going to want to obtain informed consent. So again, we'll talk about that a little bit more when we talk ethics as well. But essentially, you want to make sure that everyone in your study not only agrees to be in your study, but that informed consent part means they're consenting and they are informed. They know what your study is about. They understand what they are getting themselves into. So you want to obtain informed consent from anyone that's participating in your study. They're agreeing and they know what they're agreeing to. You next want to assign subjects to groups. This is the step that is unique to experimental studies, right? And in a case control study, all of those same steps really be true. You're recruiting people, you're getting people into your study. What makes an experimental study different is this idea of assigning or allocating people to treatment groups. So there's a couple different ways of doing it. You know, generally we don't talk about studies without comparison. We can, but an experimental study, and studies without comparison can include something like a case series or case study. This is really when you just are following people who might have undergone an experimental treatment. You're not really comparing them to anyone. While that is anecdotally interesting, it's really the comparison that makes an experimental study strong. So I would say studies without comparison are not very strong studies. We then have studies with comparison that are, I would say, less strong, that are what we're going to go over next. We have something called historical controls. So we can compare essentially people who have undergone a treatment. We can compare them to people in the past who didn't undergo that treatment because maybe it wasn't available. We can do things, we can do something called self-controls. This is kind of the before and after that we mentioned. Someone can serve as their own control. You know, if, again, we have a new drug for a headache, we can say, all right, you know, this population, we're going to look at how they responded to headaches, how long a headache lasted in them before we gave them this new drug. And then we're going to look after we gave them this new drug. So that would be a self-controls, this kind of before and after. And then we have something called simultaneous non-randomized controls. This sounds a lot more complex than it is. Essentially, it's just letting people assign, it's essentially assigning people to groups without randomization. So we'll talk about randomization next, being kind of a really important, strong thing in experimental studies. But we can do experimental studies where we don't have randomized controls. You know, we can allow people to choose their own groups, treatment versus control. We can essentially assign people to groups based on a factor that we've identified. So maybe we assign the more severe people, severe cases of disease to the treatment group and the less severe cases to the control group. Both of those strategies will inherently be a little bit biased though. And we'll talk about why when we talk about randomization next and why it's so good. But it is a method that can be used. So what I do want to focus on, and what is really powerful, one of the, besides that level of control of exposure, and it kind of goes hand in hand with this, one of the other reasons why experimental studies are so much more powerful just in general of a study design is because you have that level of control and you can randomize treatment. Randomization is something we love in experimental studies. Essentially, randomization is the process of assignment of subjects to groups for experimental or control regimens by chance. Again, kind of a longer way of saying we are taking people and assigning them to treatment and control groups, because that's the two groups we're comparing, right? We have our exposed and our unexposed, our treatment and control. But we're assigning people to those groups. You're in treatment, you're in control. We're doing that by chance. We're doing that by randomization. So we're flipping a coin to tell people what group they're in, essentially. the big critical element is that unpredictability of the next assignment. We are assigning people by chance, meaning if I tell you that you are in the treatment group, that shouldn't give you any information about what your friend in the study is also going to be in. That's what we mean by unpredictability. It's just chance. It's essentially a coin flip. We can do it in a lot of different ways. I mentioned a couple ways, using a table of random numbers, unmarked envelopes. A statistical software can do a randomized algorithm as well. Again, I just want you to be aware of what randomization is and why we do it. I think it's in biostatistics that you're going to go, if you haven't already, a lot of you might have, you're going to go into randomization in a little bit more depth on the different strategies to use to actually randomize. But for our purposes, I really want you to know why we do randomization and what purpose it serves, because it's one of the best and most important things to know in an experimental study. And the reason that we do randomization, the reason that we said the other experimental designs types weren't as good is because the whole idea behind randomization is we're trying to obtain similarity between the groups that we are interested in comparing. So we have our treatment group, we have our control group. Obviously the big difference is the treatment, right? One group, it has an exposure that we're giving them. One group does not. But we would like all the other factors, if possible, to be similar when we're comparing both groups, because we're trying to see in an experimental study the effect of the experimental treatment, the effect of that exposure. If, let's say, all the male participants were in one group and all the female participants were in another group, and we were treating them, we were saying, the treatment group gets this new drug and the control group doesn't. Well, the tricky thing is we don't know if it's the treatment itself or gender, which is having an effect if there is a difference between groups. So randomization tries to obtain that similarity between the groups. Couple key elements. It is done after informed consent, so we're doing it once participants are already recruited into the study and after they've already agreed to participate and been informed about what they're participating in. It is not the same as random selection. So randomization, we're assigning people to treatment groups. Random selection, we're randomly selecting people into our study. Both can be done in an experiment. Only randomization can be done in an experimental study versus the other study design types, though. So random selection, we have a cohort study, we have a case control, we can, imagine our class, right? I want to do a cross-sectional study of our class. Maybe I randomly select 10 people from our class, ask them about exposure and disease. Randomization, on the other hand, is assigning people to treatment groups. I can only randomize when I have an experiment because that is the only study design where I'm randomizing people, where I'm assigning people to treatment groups, where I have that level of control. Randomization can increase the likelihood that groups will be comparable. That's why we're doing it, right? We said in the last slide, to obtain similarity between the groups. Randomization will help with that. But because the whole idea of randomization is it's based on chance, randomization doesn't guarantee groups will be similar. So essentially, if I want, in my mind, I think gender might skew my data. I wouldn't, though, when I'm randomizing, I would want to randomize people to groups. I'm hoping that randomizing does a good job of evenly distributing genders between the two groups. But there's no guarantee, just like, with anything, you can coin flip and maybe all males wind up in the treatment group and all females wind up in the control group anyway. Randomization is just chance, right? It allows for that possibility to happen. That's the whole idea of it. So it does not guarantee similarity of groups. So that's kind of the big key point I want to hit home. It is a fantastic, useful thing, but it doesn't guarantee similarity. If we want two groups to be similar, if we want there to be an equal proportion of men and women in our treatment versus control group, well, we can just make that happen by matching, but that wouldn't be randomization. The good thing why we would do randomization and I wouldn't just choose something like matching is there could be tons of different factors, some we know, some we don't, that could affect our data. Randomization essentially will try to obtain what it's doing is it's obtaining an approximation of similarity in groups, again, through that chance for all those factors. So unlike having to match, oh no, gender is going to mess with my data, so maybe I'll make gender proportionally equal in both groups. Age is going to mess with my data, so I'm going to do that with age. If I have tons of different factors that I'm worried about, randomization can really help with all of those factors potentially. So that's why we like randomization. And that's why when we're talking experimental studies, generally we're talking about randomized controlled trials, because randomization is one of the most powerful things we can do within an experimental study. An experimental study itself is just having that level of control over exposure. But what we would ideally want to do with that is we want to randomize. So questions about randomization? Why we do it? And definitely let me know. I don't want to go over anything kind of important too fast. So I know it's harder to judge, you know, online versus in person. But please stop me if you have questions. All right. So the next step is to begin treatment. Essentially, experimental, what we've done is we've assigned people to groups, right? We have a treatment, we have a control group. The control the treatment receives the treatment, let's say the new drug, a vaccine, some kind of intervention, and the control subjects receive some alternative. Maybe the control subjects receive nothing. Maybe the control subjects receive a standard treatment. So if there is a treatment that is pretty good out there, we cannot, excuse me, we cannot allow our control subjects to be worse off in our study than they would have been in kind of the rest of the world. So if there's a treatment that is accepted and that is pretty darn good, especially for something that is kind of severe or serious, let's say a cancer drug that extends life, if we hope our cancer drug makes people live for 10 years, but there's already a drug out there that makes people live for 5, we have to give that control group, that unexposed group, we have to give them that standard treatment from an ethical standpoint. And there are ways, again, it really depends on severity of kind of what impact it's going to have. Or, again, we can give them absolutely nothing. We can give them the standard treatment, or we can give them what's called a placebo. So I know a lot of you might be familiar with what a placebo is. A placebo is essentially an inert, kind of a medication that has no effect. It's an inert medication or treatment administered as if it were therapy, but which has no actual therapeutic value. So essentially, it's a sugar pill. I give you something that I know is not going to do anything. And the reason that we do that is because of something called the placebo effect. So the placebo effect is an effect attributable to the expectation that treatment will have an effect. So let's say I have a pain medication, right? Let's say people start off, I have my treatment group and I have my control group, both of which start off, let's say, at an average of a pain level of 9. In my treatment group, I'll say treatment, control. if I give someone a drug, and this is kind of, I'm sure you've all experienced this as well, you have a headache, you take an Advil, 5 minutes later, you're feeling fantastic, you're feeling much better. There's more than likely a chance, I know this happens to me all the time, almost, immediately, you're not going to feel an actual effect of the medication. What you're likely feeling is the placebo effect. You've just done something, you've taken something, and you think you feel better simply because you've taken something. That's the placebo effect. So what we're trying to do with the placebo is we're essentially trying to counteract that effect, because we know just by giving the treatment group something, it's likely for something subjective like pain, like mood, it's likely that people will feel better just because they've been giving something, regardless if the medication actually works. So maybe in our treatment group, we see their pain level go down to a 4 after we give them something. The reason that we would give the control group a placebo is because we want to kind of pull out, all right, what is the effect of the placebo? What is the effect of just being given something? And how does that differ from the actual effect of the medication? I know that, even if I feel better a couple minutes after taking an Advil, that's probably just me feeling better because of the placebo effect. But the medication is actually and will actually likely work, and we want to see how well it works. So if our control group, maybe the pain level goes down to a 7 after we give them our placebo. Remember, the placebo hasn't actually done anything. There's no actual medication in it, but people felt better a little bit, right? Their pain level went from a 9 to a 7. People felt better simply because they were being given something. So we, as the researchers, what we're doing is we're teasing out, all right, the difference between a 9 and a 7, that's just the placebo effect. It's this difference here between a 7 and a 4, that's our treatment effect, right? That's the difference that we're seeing between people in the treatment group and people in the control group. So that's really why we use a placebo, to kind of tease out the effect of just being given anything and how that differs from being given our actual treatment. So questions about what a placebo is, why we use it. Any questions at all? And definitely feel free, stop me as we're going if you have questions. We'll keep going if I don't see any. Or again, take over the mic. You're welcome to ask questions that way too. All right. So when we might use blinding or masking is something we would use kind of in conjunction with a placebo. Masking or blinding is essentially when subjects or investigators are kept from knowing which treatment group they're assigned to. Essentially, if we have a placebo, we're not going to tell someone, we're not going to tell people in the control group, the placebo group, we're not going to tell them that it's placebo, because we're essentially telling them we're not giving you anything that's an actual drug. What likely we're doing is we're going to give a pill, let's say, and they could take a lot of different forms. We're going to give a pill to both groups and not tell them whether or not the pill is the treatment or whether it's a placebo. So the reason that we would mask is when we don't want people to be skewed. We don't want people's opinion of something subjective like mood, like pain. We don't want that to be skewed by knowing what they're being given. So again, kind of used in combination with a placebo very often. We can do what's called single blinding. This is when subjects are not aware of their treatment assignment. Or we can do what's called double blinding, when the investigator and the participants are not aware. So in generally, we would want to do double blinding if, let's say, we're worried that any kind of bias could come up on the investigator's point. So if we're worried the investigator is going to, maybe question one group a little bit more heavily, or maybe kind of, ask them, oh, are you sure your pain hasn't improved at all in our treatment group? Well, maybe we just don't want them to know which group people are in because we want to reduce any possibility of bias. Right? We talked about aiming questions. We don't want them to aim questions towards one group versus another. So we just prevent them from knowing what group people are in. And then anything that they're going to be doing similarly to both groups. So that's what we mean by masking. So questions about masking before we move on. So I will say 2 things about masking, and we'll kind of revisit these when we talk about issues. Blinding or masking is great, and obviously we would want to do it in conjunction with a placebo, but blinding is not always possible, right? If we have something like we're comparing a surgical intervention with a drug, we can't really tell people, oh, we're not going to tell you whether or not you underwent surgery. No, we would have to tell people, okay, you're going to be in my surgical group, you're going to be in my drug group. So blinding, depending on the exposure of interest, not always possible. Blinding is also not always successful, even if it is attempted. We might be doing, a study where we give one group a placebo, a pill, let's say, and one group the actual treatment, which is a pill. But maybe one of the pills, and we try hard when we're using a placebo to have this not happen, but maybe one of the pills has a certain flavor or a taste that's different than the other. That could give away what group someone is in. Maybe one has a side effect that another doesn't. That could give away what group someone's in. So blinding's not always possible, depending on the exposure or the treatment. And blinding is not always something that, even if it is possible, is successful. Doesn't always work. It's not always possible, even if it is something that we can do. So any questions about blinding at all? All right. Then we're going to follow study outcomes. Study groups for outcomes. That's kind of our next step. We're going to look for the outcomes of participants. Did someone get better? Did they not? We're going to look at the side effects, any side effects of treatment. So we're going to compare those side effects in both groups, our treatment and our non-treatment group. And we're also going to measure something called compliance. This is something like if we give people pills, maybe we count the number of pills they have left. We ask them, did you take the pills? We measure the level of drug in their blood system or in their urine. Right? Compliance is essentially asking them, did you do what we asked you to do? Did you did you kind of keep up with the actual treatment regimen you were assigned? That's compliance. So just to give you an example, again, kind of an overview of what it would look like. We have 1,000 patients. We randomize people. Let's say, and again, this is totally dependent on the exposure. In this case, let's say a new vaccine. We have 500 people we're assigning to the new vaccine group, 500 people to our old prevention group, and then we follow them to see whether or not they get a disease. So just to kind of give you that visual like we had with the other study designs, this is a visual of our experimental design. The key thing here being this randomization process, the key thing here being we are assigning people to groups, right? Through, in this case, randomization. That follow-up is inherent to experimental studies, but it's also present in cohort studies as well. So it's this process of assigning people to groups by chance and assigning people in general that makes it an experiment. All right, so this is where I will tell you efficacy. I want you to know what efficacy is. I will not ask you to calculate efficacy. Your book talks about it. I included it on the slide just in case we had time. But, given our time frame, I want to save enough time for questions. So we're going to skip over the calculation for efficacy and really just talk about what it is. So efficacy is the measure that we would calculate in an experimental study. Essentially, efficacy represents the best case scenario of a vaccine, an intervention, a new drug. It essentially, just like the risk ratio, just like the risk difference in our cohort study, just like the odds ratio, it's essentially telling us, is there an association between exposure and disease? But the key thing I want you to know here is efficacy is what does that. It tells us essentially what's for a vaccine, the protectiveness of the vaccine. For a treatment, it will tell us the benefit of the treatment. Again, depends on the exposure. But efficacy differs from something called effectiveness, because efficacy essentially tells you that best case scenario of that treatment under controlled conditions in a randomized controlled trial in an experimental study. Efficacy is that best case scenario. Effectiveness is a term you'll also see. Effectiveness is essentially a similar calculation, a similar idea, but effectiveness is a real-world view of how a vaccine or how a treatment reduces disease in a population. It's essentially this real-world idea versus the best case scenario in a trial. So oftentimes you'll see both measures reported. So for example, oral contraceptives for pregnancy, you might see the efficacy is 99.9% at preventing pregnancy, but the effectiveness is going to be lower than that because in practice, people misuse pills, people forget pills, there's a lot of issues when that comes up. So that's effectiveness, a real world view versus efficacy, that kind of best case scenario. So in terms of establishing procedures, I do want to kind of wrap up our lecture here. So in terms of establishing procedures for ending the study, there's different reasons why you might end the study. So I'm not going to spend too much time focused on this. It's not something I'm going to focus on for the exam. But, I do want you to know when and why you might end a study. Some issues with an experimental study, these are going to be the last things that we'll talk about. We've already talked about these two. Randomization might not have worked, right? Randomization doesn't guarantee anything. And, if we blind or if we mask participants, we said it's not always successful, right? Two of the big, cool things that we can do in an experimental study might not work well. But really some of the biggest issues in the experimental study come from the process itself. People might not comply with treatment. And really one of the biggest reasons why we don't use experimental studies more, we use them a ton, but why we don't, default to them is oftentimes we're bound by ethical considerations, right? So we are giving people treatment in an experimental study. We are assigning people to treatment groups. If it's something that's harmful, we cannot do it. We can't say, this group you smoke for 20 years, this group you don't. Let's see what happens. So, and then similarly to our cohort studies, they can be expensive, right? They can be expensive, time consuming. We're following people for a period. People could drop out of the study, right? So loss to follow-up's an issue, expense is an issue, resources are issues. People who volunteer for the study might be different from those not willing to participate. So all of those are kind of inherent issues based on the design itself. I would say the biggest issues besides expense, besides loss to follow-up, which are true in something like a cohort study, some of the biggest issues are really that ethical consideration. We just can't do an experiment if we know something might be harmful. So I do want to wrap up the slides there. Any questions, though, about the experimental studies in general? I do want anyone who wants to, again, I'm not taking attendance today, obviously, but I do want anyone who wants to stick around for a review of the study guide to kind of go over any questions that you have. So let me pull up the study guide itself. I know there was a question on that at the beginning. All right, love the study guide. All right, so any questions? I want to first, let me just remind you that the study guide's posted. Your homework 4, which is due today, is also posted. Practice problems for the study design and answers are also posted. I encourage you at the very least open the practice problems answers and just make sure you're making the interpretation correct for kind of each of these. Let me pull up the study guide. All right, so questions in the last 7 to 10 minutes of class. Any questions that you have on the study guide?
Yes.
Excellent. Okay, so we can hear you. I can hear you, at least. All right, what questions do you have?
Yes, I want to ask you in that calculation about the observational studies. I want to know if in the test you are going to ask, we have to calculate, for example, the case study specifically, or you are going to do the problem and we have to know each one, we have to do the calculation.
So the calculations that I'm going to ask for on the exam, I try to include, for a cross-sectional study, I will ask you about the prevalence ratio. So I'll ask you to interpret, let me annotate here. I will ask you to interpret the prevalence ratio in a cross-sectional study. I will ask you to interpret the 3 measures that we talked about in a cohort study: the risk ratio, the risk difference, and the attributable risk. So let me point that out. So that's kind of here. And then I will also ask in a case control study how to calculate and interpret the odds ratio. So the 5 measures essentially I'm going to ask about: prevalence ratio, risk ratio, risk difference, and attributable risk. And then the odds ratio.
Okay. Thank you.
Absolutely. Okay, so I see another question via chat. Can you please go over the purpose and functions of analytic and descriptive epi? Absolutely. So when we're looking at descriptive epi, so kind of the first question, when we're looking at descriptive epidemiology, we're looking at whether or not we're just describing disease. So the purpose is essentially just describing disease in terms of person, place, and time. If we're talking about the incidence of disease in California, that's just descriptive epi. Analytic epi is what we're doing with some of those ratios, where we're looking at the incidence of disease in one group compared to the incidence of disease in another group. And we're doing that. The purpose of that is to see if something's a risk factor for disease. So descriptive epi is just describing disease. Analytic epi is looking for risk factors for a disease. And we're doing that by comparing groups. So in descriptive epi, we're not really comparing groups. We're just saying how much disease is in this one community. Analytic epi is saying, hey, there's more disease in this community than this community. What's different? So the purpose is kind of really of descriptive, describing disease. Of analytic, it's looking for risk factors, comparing groups. So hopefully that answered that question, Susanna. Again, if you have, if I don't answer your question, let me know, and I'm happy to kind of reword. So other questions?
I have another question.
Yeah.
Regarding the homework that's due today.
Sure, absolutely.
Well, one of them, number 2, it's asking which ratio is more appropriate to calculate in a cohort study.
Mm-hmm.
I put risk ratio, but I wasn't sure if that was the correct answer.
That's exactly right. So in a cohort study, you're going to want to do a risk ratio. In a cross-sectional study, you want to do a prevalence ratio. In a case control, you want to do an odds ratio. But that's exactly right. In a cohort study, you would want to do a risk ratio.
Okay.
That's
and then
perfect.
On number 5 and 6, I was having a hard time distinguishing like interpretations of risk difference.
Sure.
And the attributable risk percent.
Absolutely. So when we're looking at the difference, so let me pull up the homework just so everyone can kind of see what we're looking at. scooch this over. Oops. Scooch. All right. So on number 5 and 6.
Yes.
So when we're doing the risk difference, I said, oh, come here. Number 5 and 6. Essentially, when we're doing the risk difference, in this case, we're looking at asthma in sawmill workers versus non-sawmill workers. Risk difference is essentially saying how much extra risk, how much extra incidence you see in one group because they were exposed. So if we were to interpret this, we would say, oop, did I not type? I'm going to just type like this. We would say kind of this much incidence in the people who worked in the sawmill can be attributed to them working in the sawmill. So essentially how much extra risk, how much extra incidence in the exposed group can be attributed to their exposure.
Okay.
In the next question, with attributable risk percent, we're essentially looking at what percent of the, so almost the same interpretation, except the risk difference is going to be decimal. So essentially saying how much incidence, whereas the attributable risk percent is saying what percent of the incidence in the exposed group is attributable to their exposure. So we would say something like, 20% of the incidence of asthma, or I should say incidence of asthma, to be clear, within the context of the problem, blank incidence of asthma in the people who worked at the sawmill can be attributed to them working in the sawmill. We would say for the attributable risk percent, this percent of the incidence of asthma in people who worked in the sawmill can be attributed to their work in a sawmill.
Attributed. Okay.
Okay. Just on the English of that, on like number, again, going on 5 and 6, if we said that 0.25 in the case of these question, cases of people in the group who worked in a sawmill with asthma can be attributed to that group working in the sawmill, would that still be correct?
Read it one more time for me.
Okay, sure. 0.25 cases of people in the group who worked in a sawmill with asthma can be attributed to that group working in the sawmill.
I would just say for clarity, switching those first couple words, I would say 0.25 cases of asthma in people who worked in a sawmill can be attributed. So I would say just flipping the words just for clarity. But yes, that's essentially it.
Okay. All right. Fantastic.
Okay.
Thank you.
Thank you.
Yeah, absolutely. So other questions, homework or the exam or the study guide? I know we are running, I'm happy to go just a minute or two over for anyone who wants to stick around. Any additional questions though? And I'll send an email reminding you about the exam, but remember the study guide, you are absolutely welcome. I'm happy to arrange a time to meet with you on Zoom tomorrow, later today, or you can just send me questions via email on the study guide. I think I got to all the questions that I saw. If for some reason didn't get to your question via email, let me know, and I'm happy to, answer questions that way. But anything that works for you, I want you to feel as prepared as you can going into this exam. So any additional questions for now? Okay, if there are no additional questions for now, I'm going to go ahead and stop here for the day. Again, thank you all so much for being here and accommodating my need to change to an online format. I really appreciate that. As I mentioned, this recording, as soon as it sometimes takes a little while to render. So I would say in the next 2 hours, you will see this recording posted on Canvas that goes through all the slides and really everything that we did today. But please let me know if you have any other questions over the next day or two. I'm happy to go over anything that you want. So thank you so much for the well wishes. I appreciate it. And have a great rest of the afternoon, everyone. I will see you all on Thursday for the exam. I should be there. I'm going to make it my goal to be there. So let me know if you have any questions before then. But have a good rest of the afternoon. I'm going to stop the recording now. Stop share.